Well, good morning, everyone, and welcome to the Empower Atlanta workshop. We are just absolutely delighted that you could join us today. We are very thankful that a number of you have joined us, not only from the Atlanta region, but in fact from the whole of the area in the Southeast. But furthermore, we know that some of you are logging in from all over the country. So we're just delighted to have you join us today. My name is Dr. Joseph Mchale. I have the privilege of being the Chief Medical Officer of the International Myeloma Foundation and work with just the most incredible team I've ever worked with in trying to find ways, as we're going to share with you today, to change the course of myeloma, which is to say that we really want to see an impressive and change in what we offer to our patients in multiple myeloma. It's also my privilege today to chair our session over the next 2.5 hours that we're going to spend together. We're going to have a really, I think, very productive and wonderful workshop, and we're very thankful that you would join us today. So I'm going to walk us through who is going to be with us today. I've already mentioned myself, of course, but we have some really tremendous people from Atlanta and the region. So Dr. Ajay Nuka, who is at the Winship Cancer Institute at Emory in Atlanta, is going to be sharing some thoughts with us around how myeloma comes back, and indeed some of the work that he's doing in myeloma. Dr. Brandon Blue from the Moffitt Cancer Center in Tampa, Florida, is going to join us for an interview style discussion where I'll be chatting with Brandon a little bit. He'll be able to tell us a bit about his background and his passion in this area. Charisse Gleason, who is a nurse practitioner at the same institute as Dr. Nuka, who is really a tremendous myeloma expert and is going to be sharing with us throughout the whole of the workshop, but specifically going to be talking to us about the reality that when we treat myeloma, we don't treat a disease, we treat a person. And it's going to be, I think, very productive to listen to Charisse share with us some of her thoughts on the whole of the body and our health in general. And then we're absolutely delighted that Jamika Barrett could join us today, who is a tremendous patient advocate in the field of multiple myeloma. And she's going to share with us several thoughts today as well. So I've given you a little bit of highlight of what we'll be covering in terms of the agenda for our first half of the workshop today. I'm going to, you're stuck listening to me, I'm sorry, but I'm going to talk a little bit about race and multiple myeloma. The whole notion of empower, as I'm going to be sharing with you later, is empowering patients and communities to change the course of myeloma. And that is to imply that the current course of myeloma is not appropriate, in particular within the African American community. And this disease that unfortunately has really been such a challenge. And so we're going to be talking a bit about race in myeloma and what really is myeloma. What is it? Some of you are very familiar with myeloma. You've been working in this field for a very long time. Others of you aren't sure if this is a blood thing or a skin thing, or so we're going to really try and demystify what multiple myeloma is and really talk a bit about how we treat this disease. And then we're going to have that interview I mentioned with Dr. Blue. And then Dr. Nuka is going to talk to us about what do we do after we've treated myeloma and unfortunately it comes back. This is a disease that we're not currently curing. We try to control it for long periods of time, but sadly, inevitably it comes back. Dr. Nuka is going to talk to us about that. And then we're going to have an opportunity for some questions. We'll take a little bit of a break. And then we'll come back in after the break. I'll talk a little bit more about this notion of changing the course of myeloma. I'll interview Dr. Nuka in talking about myeloma research that's going on, and he has been one of the leaders in the country in doing this. And then, as I mentioned, we're going to have the delight of hearing Charisse talk to us about what we've entitled Tools for Changing Myeloma, and Jamika about navigating what she calls the multiple myeloma transit system. So if you've ever been on a subway or in the underground, I think you're going to understand a little bit more of what Jamika is sharing with us. And then, of course, we're going to have time for questions. I want to take a moment to particularly thank our sponsors who have made this workshop and so many of our workshops possible, with 2seventy Bio, Amgen Oncology, Binding Site, Bristol Myers Squibb, Genentech, GSK, Janssen Oncology, Karyopharm, Oncopeptides, Pfizer, Sanofi Genzyme, and Takeda Oncology. Now, just before I dive in, a couple of things that I think are just going to be important for me to remind you as we go through that, although we're going to be presenting a lot of slides and we're going to have some discussion, and I know Kelly Cox, who often chairs many of these meetings, always reminds us to bring our HB pencil with us. We do want you to know that this recording is going to be available to you later, and indeed the slides that we have provided. So it's always good to take notes, and it's always good to obviously to be directly, actively engaged. But if you feel like you missed something, or don't worry, it's going to be here in long term, and we're going to make it available to you, and we're going to show you the resources where you can access things. Of course, we can always access things through our IMF website, which is simply myeloma.org. And I'll be sharing with you with time how you can reach out to our info line, which is open every day, Monday through Friday, and we'll give you more resources towards the end. But just to reassure you from the start that this is going to be available to you as we go through. And then secondly, one thing you might want to take notes on as you're going through, if you have questions. This is so important. We don't want this to just be a one-way street. This is going to be a dialogue back and forth. And so as you saw in the opening video, there is a Q&A tab here in Zoom. Feel free to enter your questions if you have them, and we'll take time during the Q&A to try and answer them. If you're having any kind of technical difficulty as well, there's an opportunity there to seek help, or you could even email us at meetings@myeloma.org, and they can help you with this. I know this has been a long journey through the virtual world, and most of us are pretty familiar with Zoom and these different modalities, but if you need help, we want to be able to help you so that this can really be the most productive workshop that we can have. So let's dive right into this. You know, the world has become more aware of how race plays a significant role in healthcare. I don't think any of us have not realized that over many events, in particular over the last 18 to 24 months. And I would argue that this is perhaps even more relevant in the world of multiple myeloma than almost any other disease right now here in the US. And I say that for what I often call the big 10 reasons. So I'm going to walk you through 10 reasons why I think this is so important in multiple myeloma. First of all, myeloma is the most common hematologic or blood cancer in African Americans. So roughly 13-14% of the total population of the US right now are African American. But 20% of myeloma patients are African American. And I'm going to share with you why that is in a moment, because the disease is more common in this population and growing, such that we expect over the next 10 to 15 years that this will be close to a quarter of all patients with multiple myeloma will be of African American descent. And so we will explain a little bit of why this is happening, but you'll see the significance of this as we go through, because it's so important that we care for all patients with myeloma. You know, the IMF has been committed to caring for patients with myeloma for over 30 years, and it is very important for us not to exclude any patient. This is driven by the fact that myeloma and something called MGUS that you may or may not be familiar with, which is kind of a pre-myeloma condition that I'm going to explain in a few minutes, is twice as common in this population. So the incidence, as we call it, or the frequency that we see this disease is twice as high in the African American population. So if you take a set of individuals who are African American descent and those who are not, you're going to see this disease twice as much in that population, more than twice as much as white Americans. And this is very important because it highlights how critical it is that we capture this disease early on. Not only that, it's not just twice as common, it's actually diagnosed at a younger age. And this will become relevant. We talk a little bit later about how we approach teaching doctors even about multiple myeloma, because we tend to think of myeloma as a condition much later in life. You know, the average age overall is about 69 years, and in white patients even older at 71, but in African American patients 66, and in Hispanic patients, even a little bit younger at 65. So it can present a little bit differently. Now, one of the most sad facts I'm going to share with you is fact number 4, which is survival improvements in myeloma have just not been as pronounced in the African American population. So we talk about myeloma as a success story in cancer. We have doubled and even tripled the average survival of patients just in the last 10 years. We've seen huge advances, and we're going to be sharing with you, without going into too much detail, some of those drugs that have really guided much of this, and things like stem cell transplants and clinical trials. And so we've seen huge advances, but for all the advances we've seen, we have not seen it to the same degree in the African American population. So for every almost 1.5 years gained for the white population, it's just been over half of that for the African American population, and that's clearly not acceptable. What's also not acceptable is that almost all myeloma patients have a long time between the symptoms they develop, that I'm going to share with you in a moment, and making a correct diagnosis. That diagnosis is delayed even more in the African American population, perhaps even as long as half a year. The average patient will see a family doctor 3 times for their symptoms of multiple myeloma before myeloma light goes on, as it were, to make that diagnosis. We're going to be talking about the great treatments we've developed in myeloma. One of them are what we call triplets. So that's 3 drugs used together, like a great combination. African Americans are less likely to get triplets. They're less likely to get transplants. Stem cell transplants, or bone marrow transplant, as they're sometimes called, is a really important part of treating myeloma. And we've seen over the years that Black patients have less access to transplants, and surely less access to clinical trials, what I call the 3 Ts: triplets, transplants, and trials. These are 3 things that have really improved survival in myeloma over the last several years. And unfortunately, we have not seen African Americans have the same access to it. So as I mentioned, if African Americans comprise maybe around 20% of all myeloma patients, we see less than 8% representation in clinical trials. And that's overall in general. In myeloma, it may even be lower, in the 4 to 5% range. So this is really a concerning fact. We also know that there are some biological differences, and I don't want to get too deep into the science here, but we know that not all myelomas are the same. And so we can determine how serious someone's myeloma is based on the genetics that we find within the cancer cells. So we look right into the cancer cells and find their genes. And there are certain genes that make the disease more aggressive, and certain genes that make the disease less aggressive. And interestingly, African American patients are more likely to have less aggressive forms of myeloma. So they're more likely to have something called translocation 1114, just means a little bit of chromosome 1114 joined together, and less likely to have things that we know are very aggressive, like what we call the 17p deletion, when you're missing a part of chromosome 17. And so one would think then that African American patients should have better survival than white patients. But as I showed you before, we've not seen that. But I like to end on a little word of hope here, and I know it may not be easy to interpret these curves, so I'll make sense of it, is that when we've looked at big systems, for example, like the VA system, where at least theoretically all patients, Black or white or any background, are given the same treatment, we actually saw that survival for African Americans was better. So what I just shared about the biology a minute ago actually does make sense, that when African American patients are diagnosed correctly, when they're given the appropriate treatments, they can actually do better than white patients. And historically, they've not done that, of course. And so that is the hope that we have. That is the goal that we have, to improve outcomes of patients so that we can see that happen and not see inferior survival in African American patients. And so what can we do about this? And this is towards the end of my first little presentation here on Race Matters. We all know that this is a complex solution, a complex problem. There's no simple way to describe this. We know that there are a lot of reasons why individuals don't have access, for example, to the triplets, transplants, and trials. We know why there are a lot of reasons why the diagnosis is delayed. There's a lot of lack of trust in the system. There's geographical disparities. There's a whole series of reasons. In fact, in my interview with Dr. Nuka, we're going to be talking a little bit about the work and the research we need to do to understand the problem. as doctors and scientists, we always say you got to go with diagnosis before you can go with treatment, right? And we want to diagnose this problem, and we know that it's a huge problem. But we humbly, and I would humbly suggest that there are at least some themes of success if we're going to make the situation better. And I've put them into three categories here: something we need to do in the general community, something we need to do in the medical community, and something we need to do in the corporate and regulatory community. So in the general community, we need to increase awareness, educate individuals, advocate, and truly empower people to understand this disease, so that if you're here today and you're listening in and you hear what we're saying, and you think, I know someone who has symptoms, or I have signs and symptoms that could be myeloma, that maybe you need to get to your doctor so that they can make sure that you don't have myeloma. If you know someone who has myeloma, supporting, or if you hear and you have myeloma, that we can empower you with the tools that you need to make sure your outcomes are better so that you can get access to these things. In the medical community, we need to educate better. As we're going to share with you a little bit, we need what we sometimes call cultural competence, this idea of treating patients in a way that respects their background and understands their background and relates to them in the best way possible. And that, of course, we do everything we can to facilitate access. And then at the regulatory and the corporate level, so within the pharmaceutical industry, within the government, we need to set the right policy. We need to set expectations. If African-American patients make up 20% of all myeloma patients, then they need to be involved in all of these decisions that are being made about drug approvals, things like this. And there has to be a real commitment. And I don't think this is possible unless we bring everybody together. And that's part of our role at the International Myeloma Foundation, at the IMF, to bring these individuals together. And I believe that we can do this and that we can make a difference as we go forward. Because the IMF has created our African American Initiative, which is under the umbrella of what we call our Empower Project. So we want to empower all patients. So we are doing work within the Hispanic community, within the those who live in rural areas, those who are uninsured. There are lots of different at-risk groups, but we're focusing today within our African American Initiative to improve short and long-term outcomes. And the IMF has always been built on four big pillars of awareness, education, support, and research. Awareness and advocacy, education, support, and research. And so we want to do our very best to improve this situation. So hopefully I've made the case for you that race matters in multiple myeloma, that some of these disturbing yet encouraging facts will help us understand why we're here today and how in Atlanta and across the country we want to make a difference for patients. And so we're very delighted that you are here with us, and we're thankful that you could join us. So let's talk a little bit about myeloma for patients who are just getting started. So you may not be familiar with myeloma, and so this is good for you. But let me tell you, I was just having a nice chat with a patient yesterday who said, Dr. Joe, I went to an IMF workshop last week, and I've had myeloma for 10 years, and I'm pretty much well informed. Listening to the simple introduction to myeloma was again helpful to me. And so if you're here today and you're expert in myeloma, it's still very possible that you're going to learn something, and it helps consolidate what you might know about myeloma. So sometimes I describe myeloma as of course, it's a disease of the blood. So we have to think a bit about the basics of the blood. And the blood is made of the liquidy stuff that circulates, and there's some solid stuff in it. And the solid stuff are what we call cells. And we have three kinds of cells in our blood, red, white, and platelets. So red cells are like just little trucks that carry oxygen that circulate in your body. I think of them as trucks that pick up oxygen from the lungs, deliver them to the tissues. White cells are a little bit different. They're kind of your army. They're the immune system. They're protecting you and fighting for you. And then thirdly, you have these tiny little cells called platelets that are cells that if you cut yourself, they're the first ones to get there to plug up the hole so you stop bleeding. They're kind of like the ambulance to get there first. And all three of these cells are made inside your blood factory, which is called the bone marrow. And this is where it becomes important to us. On the other hand, what is cancer? So I'm going to explain what the blood is, what cancer is, and then join the two together. So what is cancer? Cancer is just identical, uncontrolled growth. It's easier to think about a piece of lung tissue or breast tissue or colon tissue, but this is what happens. It's just growth that we can't easily stop. And so the body wants to grow. We all grow. Sometimes we grow in places that we don't want to grow, but we grow, and it's meant to be in control. But when that control is lost is when we have cancer. What's really unfortunate about blood cancers is that what is growing out of control is not skin or bone or breast or lung or colon, but the very cells that are protecting you. And so these are the ones that are meant to help and protect you, and now they have gone cancerous. And so that's what sometimes we think of as a double whammy. So you don't have the protection you normally have, but the very ones that are meant to protect you are now hurting you. And so that gets you into trouble. So myeloma is a blood cancer of what we call the plasma cell that lives in your bone marrow. Plasma cells are little cells that make antibodies. We've been hearing a lot about antibodies during COVID, right? You go get your COVID vaccine, and we hope all of you have done that, and your booster even. And what does it do? It sends a message to your body's plasma cells to make antibodies that can fight off COVID if you do get COVID. And that's what plasma cells are meant to do. So in fact, plasma cells have been really highlighted this last year in COVID. The problem in myeloma is these same plasma cells now become bad, become cancerous. And instead of making antibodies that fight infections, now they make antibodies that literally fight against you. And you'll hear this throughout. We call these the bad antibodies or the immunoglobulins. You know, we love to use words that patients don't understand, right? In medicine, that just means immune proteins or immune proteins that can help fight against bad things, but now unfortunately are fighting against yourself. And so that M or monoclonal protein, mono just means it's the same type and shape. Normally, if you have regular antibodies in your system, you got antibodies to tons of things, measles, mumps, rubella, whatever else. But here now you're developing bad antibodies or M spikes or M proteins. The myeloma is not a very common disease. It accounts for about 2% of all cancers. We expect about 35,000 new cases this year in the US, and sadly, about 12,500 deaths. I mentioned that it's twice as common in the African American population. And I mentioned that unfortunately, although we've seen this amazing improvement in survival over this last several years, there's still a group of patients that are particularly high risk, what we call high risk myeloma, where their survival has not been as great. But now, overall, we're expecting most patients can live a decade with this disease. Although, as I mentioned, we've not seen this same advancement in the African American population. Again, to just recap then, these are the funny looking plasma cells that live in your bone marrow, and now they make these bad proteins or these immunoglobulins. We have different classes of immunoglobulins, and that's why we give them these different names or letters of G, A, M, D, and E. And so people can have a myeloma of immunoglobulin G type or A type or M type as we go through. So when we think about the diagnosis, people don't walk in and say, "Oh, doctor, I think the plasma cells in my bone marrow are growing." That's obviously, none of us can feel or sense that. So the diagnosis can be challenging. So about a third of patients present with fatigue, and not just the regular fatigue, I don't feel like getting out of bed this morning, but really profound fatigue. Over half of patients present with bone pain, and about 3/4 of patients have anemia or a low red blood cell count, those trucks that I talked about that carry the oxygen for us. And this is one of the most important slides I'm going to show to you today, because nobody has a sign over their head that says, "I have myeloma." It's a very challenging diagnosis to make because there's no specific sign or symptom around it. But these are the three that are the most common. And without getting into too much detail, we have come to learn that myeloma, which is in the red bar here, is where we see a lot of those plasma cells in the bone marrow. And we see that it's damaging the body, like the bones, as I showed you, or the low red blood cell count. And I'll show you some other things. But we've learned that myeloma is always preceded by something else or something that comes before. And that's typically what we call MGUS, or monoclonal gammopathy of undetermined significance. I know that's a mouthful. You can see why we call it MGUS, because this disease can grow for many years in people's systems before it becomes very active. We're going to come back to that concept a little bit later. But when it damages the body, it typically damages it in four areas, at least one of the four areas, what we call CRAB. The calcium can be high, the renal or the kidney can be damaged, there can be anemia, or there is bone disease. And that's how we make the diagnosis. And so when people are anemic, they're tired. When they have low blood counts, they can get infections. When the kidney is damaged, believe it or not, we can get even fatigue from that. And then, of course, when the bone is damaged, we can see a lot of bone pain. Not just a little ache here and there, but tends to be deep, severe bone pain. And so this is how a lot of patients end up arriving at the diagnosis. And then now in the last 10 minutes or so that I have before we move on to our interview with Dr. Blue, I want us to think about how we treat this disease. So hopefully the diagnosis can be made more accurately. And we're going to share with you later how we're trying to train even the medical world to make the diagnosis. But when we come to choose treatment, it's not simple. There isn't a simple myeloma cookbook that says, thou shalt do this or thou shalt do that to treat this disease. This is a disease that requires a whole lot of discussion, and it'll depend on what your preference is, which I put right in the middle here, because that becomes important. We don't, as I said earlier about Charisse's presentation later, we don't treat myeloma, we treat people. And so you have to be at the center of that. And one of the things we advocate for is you have the right for a second opinion. A lot of doctors that take care of myeloma, they're great doctors, but they also take care of 50 other different kinds of cancers. And they may not have the expert opinion in a rare disease like myeloma. And so you can seek out expertise in the area who can tell you a little bit more about the disease and what may be new, what may be offered uniquely to myeloma patients, including clinical trials, as we'll talk about later. Now, I know there's a lot of information on the slide, and I'm not planning to walk through it. I just wanted to give you, almost overwhelm you with good, with something good. That is to say, we have a lot of choice of drugs to use in multiple myeloma. When I started in myeloma almost 25 years ago, we only had one or two things on this whole list, but now we have a huge list with different classes of drugs. And today's talk is not designed to walk through them. Sometimes we do a workshop where we do really detailed evaluation of each of these things. But I just wanted to give you a sense that there is treatment for myeloma. Sometimes people hear, oh, but myeloma can't be cured, and therefore it's terminal, and therefore what's the point? No. There is a point to treatment. As I mentioned before, the average patient with myeloma now lives over 10 years. And thankfully, a lot of these drugs that are being developed, which is very encouraging to me, are being developed in a way not just to hit the cancer, but to give a patient a better quality of life. More and more drugs are being given by mouth, like as a pill, or given in a short subcutaneous injection in the skin instead of long infusions. More and more drugs are being developed that allow you to retain as much of the quality of life and lifestyle that you want. And so we think of them as these big pillars of treatment. And so I'm not going to spend a lot of time on this, but again, I wanted to show this slide to you almost to overwhelm you that we have so many choices that we never used to have before. So when we do come to treat people, what do we do? What is the choice? What guides the choice between all of those drugs that I just listed in what we have here? Well, first of all, we have these, what I call principles of treating patients. And I have 6 principles listed here. Number 1, what we do in our first treatment is really important. Sometimes we think, oh, well, I got to have lots of different treatments over the time, so it kind of doesn't really matter what order I choose. What we do up front makes a lot of difference in the long run. This is our chance to really control the disease for a long time. The longest time that the disease is controlled, or what we call in remission, is often that first time. Number two, we don't save the best for last, as I've said before. Sometimes I've joked and said, save the best for last is great for a romantic movie, but not for myeloma, because we want to use our better combinations. Remember how we commented earlier that unfortunately African Americans are less likely to get triplets? Those are the very triplets, and we might even be moving towards quadruplets, 4 drugs, by the way, up front. Those triplets are what make a difference in the long term, and so we don't want to save them for later. We want to use combinations together. There's no one magic drug or pill for myeloma. It's mixing these drugs together that has really made a big difference. And what we want is what I call the 2Ds, a deep and durable remission. So whatever measure of that bad protein in your blood, the M protein, we want to see it go down, and we want to see it stay down as we treat people. And we typically do that mix and match from 3 classes of drugs up front, what are called proteasome inhibitors, immunomodulatory drugs, and monoclonal antibodies. And then early on, we decide, should someone have what we call a stem cell transplant or not? And that's typically where we divide people, is that transplant is giving a pretty intense amount of treatment. And so we want to make sure that people are so-called eligible for it, that they're ready for it, that they're strong enough for it. And based on that decision, we go down 2 kind of different treatment algorithms, where we typically give a triplet combination. And then if someone has a transplant, they get the transplant, and then they get on a little bit of less therapy. And if someone is not getting a transplant, they just remain on that therapy. So I'm going to close with 3 questions to ask in transplant eligible and transplant ineligible patients. That is really an update in what we've been learning recently. So the first question is transplant necessary? Is transplant still necessary? Well, yes, we have lots of studies just recently showing us that it still actually helps. And so we still pursue stem cell transplants in patients. Number 2, what is the best triplet combination? Is it what we call VRD with Velcade, Revlimid, and dexamethasone, or KRD, carfilzomib, Revlimid, and dexamethasone? And the good answer is both. In some patients, we choose one. In some patients, we choose another. And then the third question, which is really a hot topic and will be discussed at our a big meeting in a few weeks from now, is are we going to actually now go not just from using triplets, but using quadruplets? And I think the answer is yes, we're not quite fully there, but we're getting very close to it as we add to those combinations I mentioned, either a drug called daratumumab or isatuximab, as we give these drugs earlier on. So when we think about frontline therapy, we're going to be probably moving to quadruplets. We're still doing transplants, and we're likely going to be doing more after the transplant. My last set of 3 questions are for the patients who aren't going to transplant. So one question is, are triplets better than doublets? And we've actually now shown that this is the case. There was a day where we thought, we don't know if we can ever give 3 drugs together to patients who aren't going to transplant, because typically these are older patients, maybe a bit more frail, maybe have other conditions like heart disease and diabetes and other things that may make the transplant more difficult. But we really have seen that we can do better with triplets. Not only triplets, but question 2, how long should we treat patients? But that if patients are tolerating their drugs well, that we continue it long term. It's like controlling a long-term disease, that the longer someone has it under control, the better they're going to do. And then are there ways that we can make these combinations more tolerable? And that is a huge area of work and research, because people hear the word chemotherapy and they think bald and barf, right? I mean, that's what we classically think of this. And so we're trying to develop more and more strategies that are easier on patients. So my conclusion for transplant ineligible patients is that although we still transplant a lot of patients, we have to be careful in who we select for it. This continuous therapy or ongoing therapy has really done better for patients. And we're typically choosing from those same 3 classes of drugs that I've mentioned, either what we call the DRD combination or the VRD combination. And I've tended to use a little bit more DRD in most standard risk patients. And that we're looking in the future to maybe even doing quadruplets in this patient population as well. Again, my last slide to sort of overwhelm you is that we have so many drugs being developed in myeloma. I've just talked a little bit about that frontline therapy. Dr. Nuka in a moment is going to make sense of this alphabet soup that you see in rescue therapy. There's no way you can learn all these words instantly, but it is so exciting for me. Again, going back to when I started with myeloma, where there was maybe 3 total words on this list. And now, as you can see, it's over 20, if not even 30, of all the options and the combinations that we have. So we want to be optimistic today, realistic, but optimistic as we think a bit about multiple myeloma and what we do when we first have a patient with multiple myeloma. So you've heard way too much from me already, but hopefully if you've been napping for the last 35 minutes, in brief, we've come to appreciate how important myeloma is within the African American community and how important the first treatment is for patients with multiple myeloma. But at this point, what I would like to do is break up the discussion a little bit and start to think a little bit about talking with a true expert. And if there's one thing that I can absolutely say about Dr. Brandon Blue, is that he is passionate about what he does. It comes through in every conversation I've ever had with him. And so we thought it would be valuable to talk to a myeloma expert who he himself is African American, who has done so much for the myeloma community, not just in Moffitt. I know we're going to hear a little bit about your background in a second, Brandon, so I don't want to steal your thunder, man. But let's take a little bit of time to talk to Brandon and understand a little bit more from his perspective. So Brandon, thank you so much for joining me, my friend.
No, thank you for having me. I'm happy to talk to the folks of Atlanta and surrounding communities.
Excellent. Oh, it's great to have you here, my friend. Well, listen, they're here to hear you and not hear me. So tell us a little bit about yourself. Tell us a little bit about why you went into this field of multiple myeloma.
Yeah. So first of all, I'll say I do have a Atlanta connection. My father-in-law was the sheriff of DeKalb County for many years, Sheriff Thomas Brown. So if anybody in the Atlanta area might know him, that's my father-in-law. But so that's family. So really for me, I am the first doctor in my family, which means I had a dream and a goal, but like not really a road of like how to get there. So my story is kind of a little crazy because by chance, by God, by fate, my family, when we grew up right across the street from a nursing home. And so that nursing home, one day when I was 15, 16 years old, had a big like, we're hiring sign out front. And so, I kind of ran over and told my mom, like, hey, like I'm ready to work. And so she was like, go across the street. It was very easy. Ended up getting a job at a nursing home and really started to really kind of pique my interest in like helping others and caring for people who really were in need. I took that from high school to college and trying to figure out like, all right, well, how do I make a living with this? Like, how do I like really use that like joy that I had by doing that, but do it for the rest of my life. And so that's where really I became interested in medicine, but really like oncology, like if you say, all right, I want to be a doctor, do you want to be a baby doctor? Do you want to be an adult doctor? Do you want to cut people? And those kind of things I had no idea, but I did know that was where I wanted to be. So luckily I did well enough on grades and exams and those kind of things that it led me to go to medical school. I actually went to Meharry Medical College in Nashville, Tennessee, which is one of the HBCU universities that we have here in the country. And so it was at Meharry where I really learned like, hey, I really want to help adults. I didn't want to take care of crying babies. I knew that a knife in my hand was probably not the best thing, and so I knew that I wanted to talk to people and really kind of help them change their lives by thinking and coming up with a plan to be a significant part of their lives. So it led me to go to Washington University, which is in St. Louis, Missouri, one of the top kind of medical institutions in our country. And there is really where I saw oncology care at its peak. So one of my mentors, Dr. John DiPerzio, was really critical at kind of focusing me and kind of say, hey, this is critical to say, hey, oncology is the wave of the future. There's some cancers and some treatments that you'll see that have been the same for the past 30 years. But as Dr. Mchale really said, that really myeloma, you see the last, 5-10 years, things have really exploded. So that's very exciting to have new options to be able to help people. So I said, hey, I have to jump on this train. I have to kind of be here to a point where, I can help people. So then I said, well, one of the critical factors, as he brought up, was transplant. And I didn't really have a good sense of that. And so when I left St. Louis, I said, you know what, let me come back to Tampa. I did actually an extra year of training in what they call transplant as well as cellular therapy. We didn't really talk too much about that yet, but really we have a way of using our own immune system to fight off cancer called CAR T cells. And that's really up and coming and actually recently got approved for multiple myeloma. So I said, this is a win-win. And so for me, I said, hey, I need to come back. I need to share this new innovations, this new information that I have with the people I grew up with. So now I'm here in Tampa. I literally grew up 30 minutes down the road in St. Petersburg. And now I'm helping people that I went to middle school with, helping old principals, really people like from my community, and really helping give back. So that's why I'm here today. Atlanta's like a second home for me. That's where my wife and her family are from. But literally, we're here to help.
That's absolutely fantastic. Thank you, Brandon. What a story coming from a family where there really was no medical background. I mean, let me just commend you on your courage and your hard work to get through that. We know that medical school and training, you got. I joke sometimes you got more degrees than a thermometer, man. You know, between all of your training and hematology, oncology, and then transplant, and it really has meant so much to us. I know one of the things that you get particularly passionate about. I mean, I love how you describe that you want to give back to your community. So let's just dive into that a little bit more. You know, the whole notion of our Empower project is to get into the community to really demystify myeloma, to explain it so that people don't want to ignore it, so people can know what it is, so people can realize that, you know, you don't get it because you're not spiritual or because you don't have this or that it can happen at a higher rate within the African American community, and how important it is to make that diagnosis early on. You know, what is your perspective on that? What can we do to try and, you know, engage the community more?
Yeah, so I think one of the things that you brought up that was critically important was the triplets, the transplants, and the clinical trials. For myself, I think one of the things that's important as far as helping change health disparities is the 3 Ds: diagnosis, don't complicate things, and doctors. Okay. So number one being diagnosis. So like, as you said before, this isn't an easy thing. It's not like somebody's going to walk up to you and say, hey, I have myeloma. So then that means that as the doctors, we have to kind of tell it to people, meaning that we have to give people the news as the people coming to us saying, hey, there's a lump in my breast that shouldn't be there. That makes sense. You say, oh, that's breast cancer. Or, hey, there's blood in my stool. You say, oh, that makes sense. This might be colon cancer. But for myeloma and these plasma cells, we have no way of the patient telling us. So that means us as the doctors, we have to be more keen on the diagnosis. Okay. So then we didn't share this slide, but this is something for the people to know, that it's very important to know that not all patients present the same way. While some may have this anemia that we talked about before, or some may have the back pain, in patients, especially African Americans, it could just be their kidney function, okay? Which is a very important kind of signal that, hey, something may be going wrong in the body. So I think that as the doctors, I think we need to kind of put this on the front of our brain to say, hey, in certain populations and in certain communities, I think instead of this being number 4 or 5 on the list, maybe make it within the first 1 or 2. And I think if we did a better idea of treating certain populations where this is the most problematic, then I think what we can do is pick it up earlier, because you don't want to pick up myeloma after someone's had the bone fracture, after someone is in the hospital for this. You want to try to pick it up in the outpatient setting or in clinic so that this person can have a better quality of life. Number 2, like I said, is the doctors. So I can't replicate myself, of course, everywhere. But what I do think that we need to do is we need to focus on having more people who are in tune with the minority community. I think that these are my people, this is my family, this is why I'm so in tune with this community. But we need to make sure that we really focus and have doctors who also have similar interests. And if those doctors have similar interests, then they say, all right, well, what diseases are really affecting these folks? It's like, all right, multiple myeloma, we see it's very clear. Like, it's not even a question anymore. Like, it's very clear that, hey, certain groups, this is a problem. So how can we treat that group differently or the same as another group? We say, hey, we need to focus on this group then, and say, hey, if one group is getting diagnosed in their 70s, one group in the mid 60s, what's going on there? What's the problem? And really focus on that and really kind of put that underneath the microscope and kind of figure that out. So I do think that as doctors, I think that's one thing that we can do to really advocate for our patients, especially those who are in high risk. And then number three, I think don't complicate things. I think when people get diagnosed with any cancer, multiple myeloma included, people are scared, people are nervous, there's anxiety that comes on. And so sometimes we really try to come up with these very intricate like programs and things to like do with patients. I think honestly, at the end of the day, what people really want to know is they can trust you, that you have their best interests at heart, and that really you're here to help them. And I think unfortunately the way some of our modern medical system is, a lot of times we're rushed. A lot of times, like, there's insurance and like numbers involved, and things that really don't matter to the person sitting in the chair in front of you. So I think if we just don't complicate things, kind of go back to kind of the grassroots of medicine, of us and a patient being right in front of us, not like, sometimes we try to do the note at the same time and we're kind of there's so many distractions, unfortunately, but just don't complicate things and really make it straightforward. And I think really that person, especially minorities, a lot of times we're real loyal people, and if we feel like we can trust you and that you on our side, then trust me, it'll lead to better outcomes, lead for more enrollment in clinical trials, and really overall just better experience for the medical field. So the 3Ds, diagnosis, doctors, and don't complicate things.
I love the 3Ds. I'm going to share those 3Ds everywhere I go, man. That's really, really well said. And it particularly resonated with me what you said at the end. We can depersonalize medicine. I remember when we were designing the rooms for our clinic, and the engineer had come along and set it up that basically the computer screen was between the patient and the doctor. I'm like, no way. Like, we want that thing. So I made them put them on these sort of levers that we could push back so that I can just talk to the patient, because it's so important. We use this phrase cultural competency, and it sounds like a big word, but you just gave the best description I've ever heard of cultural competency, that we don't complicate things, that we get down face to face with the patient. Of course, there's been a big problem during COVID, hasn't it? With people not being able to even go to the doctor, that they're talking to them like I'm talking to you right now. I mean, trust me, I love talking to you, Brandon, but I'd much rather be sitting in front of you right now.
Yeah, for sure.
This face to face, and pushing aside, as you said, all the insurance problems and numbers and rushed pace. I think that is just such a beautiful lesson for the patients listening today, but also the healthcare professionals that are listening today, how important it is to get back to simple medicine. Brandon, I often share the lesson that my father taught me the day I got accepted to med school. He gave me two pieces of advice. He said, Joe, because he was a doctor, and he was trained in Africa and came over here. And he said, number one, he said, treat nurses like the professionals they are. And he said, number two, God made you with two ears and one mouth for a reason. He said, you need to listen more than you speak. And I think if we listen more, it will be helpful. Brandon, we've only got a couple minutes left, but I got one last question for you. So
I apologize. I am a little long-winded. I apologize.
No, it's good, man. No, listen, I could talk to you all day, man. You are not long-winded. This is fantastic. One of your passions is training more doctors in this area from this community. So just tell us in a couple of minutes about that, about your passion for that, and how you think we can, you came from historical Black college and university. I know in the Atlanta area, you think of Morehouse. There are other, colleges and universities in the area that we want to see more docs come out of these places and go into the field of myeloma. Of course, I want to work with them, but tell us about that.
Yeah, so I think as a tendency and as a group, as a people, we really see that there's a problem in healthcare, right? But what is advertised as the things that are on TV, or the things like, everybody wearing pink for breast cancer, or people probably even had family members with prostate cancer. Even as a medical student, I really hadn't heard of multiple myeloma. So I think that that's a very important thing to say, hey, if we want to kind of train the next wave of doctors, especially the minority doctors, to say, hey, this is a problem as far as cancer related, then we need to tell people early. Right. And so what I did, I actually gave a talk just last week to some of the medical students. And I just said, hey, do you necessarily have to be a myeloma expert? No, but you need to kind of make sure that whatever kind of, myeloma is one of those things that if you're a kidney doctor, for example, you can pick up on multiple myeloma. If you are a surgeon and you see that there's elevated proteins in somebody's blood, then you can pick up on that. So whatever aspect of medicine that you do, you need to kind of make sure that you think about this very critical and unfortunately underserved disease. And so I think that's really, really the key. And that's one of the things that I harp on when I give talks and when I kind of talk to the undergraduate and the medical students, is to say, hey, you don't have to be like me. Of course, I would prefer that everybody be included in transplant and CAR-T and multiple myeloma. Like that would be an excellent thing. But even if you don't, you can pick up myeloma in so many different ways. You can be an orthopedic surgeon and say, hey, look at this person's bones. They don't look right. Instead of, being ready to cut and focus on, something else, you might say, hey, I remember this conversation. I remember this lecture about multiple myeloma. I bet this person might fit that. Oh, he's African American. Oh, that may mean even more so, and so I just think that as a general community and as a general like medical education, I think we could do a better job. And I think that's one of the things that giving these talks, just to kind of have it on people's radar, because if you don't think about something, then you can't diagnose it, right? Like if it's not on your 1, 2, 3, then you're kind of say, well, it must be something else. I'm not sure. But if you kind of keep it there on what we used to call the back burner, right? If you keep it on that back burner, then that means it's ready whenever you're ready for it. Okay. And I think myeloma should be there for all the patients. So especially in high risk communities.
Brandon. Thank you so much. Brandon Blue's back burner. That's what I learned today.
Exactly.
That's fantastic, my friend. Well, thank you so much. Thank you so much for your passion. I hope that we are going to inspire a whole series of baby Brandon Blues to come up and join the field. So thank you, my friend. I really appreciate you taking the time. At this point now, I'm going to turn it over to a dear friend and colleague, Dr. Ajay Nuka, who is at the Winship Cancer Institute at Emory in Atlanta and has really become a world leader in multiple myeloma. Ajay, I've asked you to address the topic of when myeloma comes back. I hopefully made a case for good treatment up front, but unfortunately the disease comes back, and I know you're going to walk us through that. And I'm just going to remind the audience as Dr. Nuka begins to please, I see they're starting to come in, but please start entering your questions through the Q&A box. And when Dr. Nuka is finished, we'll take some time for the whole panel to join us and do questions before we take a little break. So at this point, I'll turn it over to you, Ajay. Thank you so much for joining us today.
Thank you, Joe, for the invitation. So I really like to extend my heartfelt thanks and gratitude to you, Brian, Susie, Diane, for bringing Empower to Atlanta to bring the awareness of myeloma, which is very well needed, just as Brandon and you discussed very eloquently prior. So what I'm asked to talk about today is, what do we do when myeloma comes back? So the first question that I start with is, why is it a question at the first place? So as you heard about the framework of multiple myeloma, Dr. Mchale had made a very good point of you get the best duration of remission with your first treatment. Using the most optimal treatment upfront is going to get us into the deepest remission possible. And it should be a durable remission, which can be improved with all the maintenances, which could be risk adapted. So at some point of time when the disease comes back, so what do we do? That is the question that I'm going to tackle today. So myeloma is a disease where you see the relapse. And when you see that relapse or when the disease comes back, there are different terms that are used: progression, relapse, disease coming back. These are all the same terms, just for all of us to be on the same page. When you see these relapses happening, you use different sets of treatments. You use a good, and again, reiterating what Dr. Mchale talked about earlier, putting the best foot forward in myeloma has always resulted in the best long-term outcomes. So nothing to say for the later time. We always want to use the best drugs at each relapse, because this is one of those diseases where the same treatment given at 2 different times, at the first relapse versus 4th relapse, you get 2 different outcomes. So it does not make any sense to preserve or save a drug for a later time. So now with that as a background, the response duration decreases with each line of therapy. So the first time when the disease comes back, you give the best treatment, and the disease comes back 3-4 years later, you give the next best treatment that is available. The duration decreases with each of the relapses. So now what we want to emphasize is how to increase this response duration with each of these relapses, because it is ultimately turning out to have a survival advantage. And this, with that, I'll go to the next slide of how we define relapse and what are the various flavors of relapse. What you see on the right is not meant for you, that M spike of greater than 0.5 gram per deciliter. This is all meant for us to be on the same page of what clearly is needed to call a relapse. So what you see in the left is probably what is more important to understand what is a relapse or what is a progression. So you heard about these terms again and again: M spike, paraprotein, abnormal protein, abnormal antibodies. These are all the same. This is a measure for us to see how the myeloma is acting. Is the myeloma is in remission? You don't find any M spike. If the myeloma is coming back, you see a small increase. This is a M spike. So this is almost, think about it like a tumor marker, which we follow to define a relapse or a progression. So now, not all progressions need to be treated. So there are certain criteria. I'll focus more onto the progressions of the relapses that really need to be treated. That is down here, that is called the clinical relapse, where the progression is associated with an end organ damage as defined by the CRAB criteria: high calcium levels, kidney failure, anemia, and bone lesions happening because of the progression. This is an area where we cannot wait. We need to jump on and start to treat aggressively ASAP. Next slide, please. So I put these in the simple context. Not every relapse needs to be treated with the same urgency. There are times where I see an abnormal protein or an M spike of 0.5 grams, and 2 years later it becomes 1 gram. And I'm watching this through the time. Understanding the relapse is the key, because those 2 years on that specific treatment, we want to squeeze out all the benefit that we could get from the current treatment that you're on. Just because there are new treatments that are existing there, just because you meet the criteria, does not mean that you need to jump onto a new treatment. So what I do not like is a knee-jerk reaction. You have a relapse. This is what we see. We need a change in the treatment. So next slide, please. So I'll put all these, how do we define these treatments into 2 buckets? The first one is, what are the factors that we need to take into consideration before changing the treatment? Next one is, what are the options that we have? And we'll talk a little bit about the clinical trials as well. So what are the factors that we would use in choosing the next treatment? It is very important for us to understand what are the prior treatments. And I'll go into detail of why we need to understand the prior treatments. The next one is the patient-related factors. Not every patient is the same. Some patients with heart failure, some patients are with kidney failure. We need to choose the right treatment that is really manageable for that specific patient. So that is what I meant by the patient-related factors. The third one is the disease-related factors. You must have heard me say it again and again. Not all myelomas are the same, and each of them have to be dealt very, very differently. And some of these need a more aggressive, urgent treatment, initiation of treatment than the others. Next slide, please. So looking closely at the prior treatments. So what is the information that I would gather from a prior treatment? So some patients tend to have a prolonged treatment. I'll give you the example of the transplant. So transplants, we don't use the transplant at the time of a relapse as often. But if somebody had a transplant back in 2011 or 2010, and now they're relapsing, last week I proposed a transplant to them, not fully understanding that the benefit may not be for the next 10 years, but at least we could get the next 5 years at a half the benefit of what we got from the first transplant. So those kinds of information would help us to understand the sensitivity of the specific disease to the prior treatments, right? So the same way, understanding what are the prior treatments that you did not tolerate well, what are the prior treatments that you're sensitive to, and what kind of a status that you have in terms of the sensitivity or the refractoriness to the prior treatments. This is all very important for us to understand so that we understand the nature of the progression, understand prior treatments, what this clone is very sensitive to, and what this clone is not sensitive to as well. Next slide, please. So to summarize simply, one size does not fit all. Knowing about the prior treatments will help formulate the new plan because your myeloma may be more sensitive to specific therapy. And more importantly, what we don't want is if you had a real toxicity to your prior treatment, we don't want to be using the same kind of a treatment. One example that I always give is the Velcade or bortezomib. You've heard, most of you have heard. If somebody has neuropathy, which is lasting for a long time, that is not the treatment that I would really want to use as the next line of treatment when the treatment is really needed. So this is very helpful for us to understand what prior treatments that you got and what are the toxicities that you had and what is the response that you got to those specific treatments. Next slide, please. So the next factor is the patient factors. We talk about, I have patients in the clinic who are in their 40s, not probably as fit as some of them in their 70s. Not everybody is the same. We're all human. We do have different comorbidities, other health conditions that go along with us, performance status, comorbidities, and even the toxicity, the example that I gave with the neuropathy with the bortezomib happening during the prior lines. All of these will help us to understand what is the best treatment to formulate. So patient factors is extremely important. If somebody has congestive heart failure, using Kyprolis or carfilzomib, which can accentuate that congestive heart failure, may not be the right choice. So the patient factors are extremely important in understanding and making the right choice for the regimen. Next slide, please. So again, not every patient is the same. Age, other existing illnesses will allow for choosing or not choosing certain treatments. I saw a patient yesterday who came in with a subdural hematoma, and he shared a history of a subdural hematoma. Now I'm making a choice of whether we should use lenalidomide in this patient. It is a little complex when I talk about individual patients, but if by using lenalidomide, if I'm increasing the risk of a thrombotic event or a clot and using the aspirin to prevent those clots, would I be increasing the risk of another subdural hematoma? That was a question that I was questioning myself. Like every single time when I see a patient, this is when I'm formulating a plan, everything goes in the background. What are the risks that we're taking with that specific choice of the agent to what exactly is the benefits that the agent is allowing us to gain? And you make the right determination based on all of these factors put together. Again, some treatments may not be safe for the patients. And the one thing that I always want to highlight is this is a dynamic scenario. At some point, you may not be that treatment may not be right for you. That does not mean that the treatment may not be right at a different time. So having the conversation again and again, bringing those agents from the past where at that specific point where that treatment may not be appropriate, it does not mean as a blanket statement that is not the right treatment down the line. And more importantly, the patient preferences. So if there's a patient coming from Tifton, I could have the best drugs with the best activity against myeloma. But if this is asking the patient to come here 2 times in a week, it is practically not possible. And choosing the right regimen, an oral regimen, which may not be the first choice, but it is allowing for them to come in here. All of those, again, fall into play when choosing the right regimen. Next slide, please. So disease-related factors. I'd like to spend some time here. There are some of these diseases, the high-risk disease, as Dr. Mchale alluded to before, as deletion 17p and translocations of 414, 1416s, and they present as an aggressive. They present very aggressively at the time of the presentation. They present aggressively at the time of the relapse. There is some urgency. There is some certainty in terms of what we needed to do right at the time. And this is a patient population. Even if there's a slight biochemical increase, my vigilance significantly increases, and I want to treat as early as possible. So high tumor burden or any of those clinical relapses that we talked about, where the myeloma is presenting as a relapse, causing an organ damage like a renal failure. Those are the ones that we want to put out the fire right away so that we're back into the game in terms of trying to see what is the right option for you. So there is one genetic alteration. I don't know how many of you know about this. This is translocation 1114, where a piece of the chromosome 11 it has exchanged the genetic material with chromosome number 14. So this has a significance. So the significance is there is a new treatment that is not approved for myeloma, but that is approved for lymphomas. And we use it as an off-label at this point of time for this specific patient population because they respond extremely well. So the responses are close to 90%. If you're used specifically in this specific patient population. So if you do not know whether you have this genetic alteration or not, next time you visit your doctor, please ask and find out. And more importantly, this is in high prevalence in African Americans compared to the Caucasians. Next slide, please. So again, summarizing, myeloma is not a single disease. There's a lot of flavors. And high-risk myelomas need to be dealt with aggressively with combination treatments, and certain genetic alterations like the translocation 1114 will allow us to use different treatments. It is increasing an extra line of treatment or using another drug that we commonly don't use, and that is allowing for us to gain some more PFS or survival advantage. Some treatments with urgent chemotherapy are necessary to put out the fire. So next slide, please. So here are all the available options. The class of drugs that we commonly deal with are the IMiDs, the thalidomide, lenalidomide, pomalidomide, and PIs, the proteasome inhibitors, the bortezomib, carfilzomib, and ixazomib. And antibodies, you may have seen daratumumab, isatuximab. These are the naked antibodies directed at CD38, and XPO inhibitors. These are the exportin inhibitors, selinexor. Antibody drug conjugates called the belantamab. And the CAR-T is called the ide-cel, which was recently approved in May of 2020. Next slide, please. So these act very, very differently, and IMiDs bind to cereblon, and they have direct action on the myeloma cells as well as enhance the immune system to fight against myeloma. The three drugs that we talked about are thalidomide, lenalidomide, and pomalidomide. Next slide, please. This is the fourth agent. Now we are using a different name for this called the CERMODs. These are highly effective, more effective than lenalidomide and pomalidomide in not only binding to the cereblon, also degrading at much lower concentrations than what we normally need for pomalidomide and lenalidomide. More effective treatments coming down the line in the near future. Next slide, please. These are the proteasome inhibitors. They act very differently. This is a hollow core. This is like a meat grinder that I always put it as. All the cellular proteins are dumped into this, and they're broken down into amino acids. And this is very much essential for the life of a plasma cell. And now we are disrupting this machinery so that the cell raises a distress flag, and the body's immune system is going to take care of the plasma cell. That's how these proteasome inhibitors work. And depending on where the affinity for each of these proteasome inhibitors are, the toxicities differ. So that's why you see very different toxicities for carfilzomib versus bortezomib. Next slide, please. This is daratumumab, a CD38 monoclonal antibody, and this acts in a lot of immune ways to cause the myeloma cell death. This is a passive immunotherapy. Isatuximab also exactly works the same way. And glad that we have the availability of these monoclonal antibodies. Next slide, please. So among patients who had received the triple refractory disease, the survival outcomes are not as good. But when we keep looking at the retrospective analysis, the median overall survival was close to a year among those patients that are refractory to a PI, IMiD, and a CD38 monoclonal antibody. For those patients, the options that existing are exportin inhibitors as well as antibody drug conjugates. If you can go to the next 2 slides, please. Yeah, this is selinexor. This is blocking the exportin and leading to a nuclear retention of these tumor suppressor proteins that could help with the tumor control, is what really helps with selinexor. If you can jump to the next 2 slides. Great. So here are the CAR T cells. These act very, very uniquely. This is one that Dr. Blue was mentioning about. The T cells are something that we all require in our body to perform that immune surveillance. So the T cells that are needed in me, Dr. Mchale, everyone, are helping us to prevent the infections, helping us to identify those occasional cancer cells that pop off and take care of them. So, which brings to the question, if there are T cells that are really doing the immune surveillance, why did I have myeloma? So the T cells probably are not recognizing the myeloma. So a simple process of taking those T cells by what is called leukapheresis and sending them to a manufacturer that can express a receptor, a synthetic receptor. Here in this case, the approved one is called the BCMA, which can recognize the myeloma cell and making an army of these CAR T cells outside the human body and introducing them to the patient after giving a lymphodepletion therapy leads to a significant myeloma cell death. And this is the one that has been approved by the FDA in May of 2021. Next slide, please.
We have about 1 minute left, Ajay, just to give you, unfortunately, a little bit of a rush here.
Sorry about that.
No worries, man.
I'm almost done. If we can move to the next slide. This is the study that led to the approval of CARMA. So belantamab works very differently in terms of its activity. It is delivering a payload directly to the target cell of the myeloma cell, and it has a unique activity, unique toxicity signal. But the toxicity signal that we all talk about is the eye toxicity. But I've never seen anybody not recover their ocular functions back, and never seen anybody have permanent damage from this chemotherapy or from this ADC. Next slide, please. So there are a lot of options that we have at this point that are FDA approved. And more importantly, what I'm going to focus is to talk about the available options that you can avail if you're a proactive patient as part of a clinical trials, and which are otherwise not available. Next slide, please. And next slide, please. So there are several anti-myeloma agents in the relapsed refractory myeloma space. So no one size fits all does not apply here. There are several factors that we take into consideration. Even though there are several approved FDA combinations, as had been shown in the previous slides, the more proactive patient, I would say, always makes the best of the scenarios where there are effective agents in the pipeline as a form of clinical trials. And by availing those opportunities earlier on, you're already ahead of the game. So at this point, I would conclude saying when myeloma comes back, there is hope and promise. Don't panic. There's always an option, and we'll make the best use of the situation. I'll stop there. Sorry, I ran a little over, Joe.
Thanks so much, Ajay. It was a great talk, a lot of great information, and we're getting lots of questions in. So I'll bring the whole panel up. If you can turn your cameras on, panel, and just remind people that you can enter the question Q&A In the Q&A box, you can enter your questions. We'll cover some of the questions that are there now, but we also do have time for some questions at the end after our next set of presentations, after we have a quick break. So I'll just start with a couple of these, and then I'll direct a few to each of you. So quick questions. Are myeloma patients cured in remission with MRD negative over 2 or 5 or 10 years or longer under your algorithm? So this is a great question. We didn't really get into something called MRD, or minimal residual disease. This is where we can test the bone marrow for any tiny amount of myeloma that's left. And if we can't detect any, we call someone MRD negative. This question is really begging the notion of what is cure in myeloma. And we're a little hesitant to use the word cure, but if someone does get to MRD negativity and stays there for several years, we believe that's the path towards cure. We're just always cautious because we have unfortunately seen people whose disease can indeed come back. Here's a question, Ajay, again, quick answer if you could. You know, you mentioned that with each relapse, unfortunately, the time in remission gets shorter. Well, a great question here. Is there ever a time when the treatment that resulted in your remission of maybe even more than 2 years might be the best therapy after relapse? So is it possible for someone to get a longer remission after their first relapse?
So that's a great question. In fact, what it is suggesting is the sensitivity of the drug to result in that remission for that specific duration. Absolutely would be my first choice. I'm fully understanding, number one, why did we stop the drug at 2 years? Is it because of toxicity? If this is because of toxicity, then I would want to understand why the toxicity. But in the absence of that, if it is a planned stopping and you have already remained in stringent complete remission by the time when it is stopped after a certain duration, probably, and if there are no contraindications at the time when you wanted to start down the line, 20 years down the line, absolutely the best way to go.
Yeah, I think we're learning, right, that myeloma is a strange disease, and sometimes certain drugs work really well in people. In general, the best treatments early on make the biggest difference. But we do sometimes see, especially with all these new fancy drugs you mentioned, we now sometimes see people get their best response later in the disease course with these new drugs. Charisse, if I could ask you this one, great question. What happens when you become allergic or have reactions and become intolerable? Are there no other options? Does this mean that it's the end for people?
No, that's not the end. You know, and it certainly happens. I would not say that's real common, but we have to look at what are the type of reaction that a patient's having, and where they are from a disease standpoint, and what other options at that point, or is there something additional that we can give to kind of control that? Or just needing to go to something different. Don't see a lot of that with our actual myeloma treatments that I can think of, really. I don't know about the rest of the panel, but you know, things sometimes with some of the additional supportive things we give, we can see a little bit more of that with things like immunoglobulin, like IVIG, that kind of thing.
Yeah, I totally agree with you. I think when people get a rash, for example, from an immunomodulatory drug or have an infusional reaction, more often than not, we can control it and keep people on treatment. I think that's a really important lesson. Brandon, if I can ask you this question, you were talking about other doctors being involved in other symptoms and so on. This is very interesting. When I was pregnant 31 years ago, I had protein in my urine. Could this have been an early sign of myeloma?
Yeah, that's an important kind of distinction. All protein is not myeloma protein. I will say that. So that's important to kind of recognize and understand. Honestly, and it's not even the most common, to be honest with you. There's a well-documented protein that is normal inside our body called albumin. It's not a cancerous issue, but it is something that does happen. So, for example, if you take someone who has hypertension or high blood pressure, or someone who has diabetes, they can get protein in their urine. Someone who's pregnant can get protein in their urine, but it's typically this albumin or non-cancerous protein majority of the time. Could myeloma happen also? Sure. But if common things are being common, those things are much more likely to cause kidney damage just because they're so much more common. You probably have met a person with diabetes. You may not have met someone, this is a targeted group, so what we call preaching to the choir, but before you may have had contact with myeloma, you may have never even heard of it. So some of those other things, blood pressure, diabetes, pregnancy, can in themselves, especially in the minority community, a lot of minority women get something called what they call pre-eclampsia. So that does increase the risk of protein in the urine. So there could be a lot of other things, but for sure the doctors on their radar can also have that as what we call on the back burner. It's not on the front burner, but it could be on the back.
Yeah, we've heard twice today about Brandon Blue's back burner. I'm watching you. That's great. We're going to take just about one more minute here. Ajay, here's a great question. Is there any of the research that shows that there are different considerations for African Americans for frontline therapy or after relapse? And Ajay, I'll get you to chime in there first. I may make a comment or two, and then we may have to head to our break.
Absolutely. So we're learning more and more about this aspect. So why can't we have the real answer? More related to the lesser participation of African Americans in the clinical trials. So none of these trials would allow for us to go back into seeing are African Americans really getting the same kind of a benefit compared to the others. So now, in the more recent years, there was a study called the Griffin Trial. The Griffin Trial evaluated addition of daratumumab to RVD, or the standard of care lenalidomide dexamethasone, versus RVD alone. So this trial we participated in, and we probably have close to 30 to 35 African American patients among this trial. But if you look at the RVD versus RVD in whites versus blacks, you're clearly seeing the stringent complete responses of close to 32% or 33%, which is what is exactly expected from this regimen. But when you see the addition of daratumumab has significantly increased the responses to close to 70% in African Americans compared to only 40% in the Caucasians. So this is in no way saying that we potentially would get more responses for all African Americans. What it is giving us is a signal that biologically with the immune therapies, there could be some differences that it needs to be further explored. So that is an example. The same thing applies to the CAR-Ts. The same thing applies to usage of Revlimid. And there are several distinctions that we're able to see by the race. And these need large trials to be done specifically in these patient populations to understand or validate what the initial observations are.
Yeah, very well said. I mean, I think the take-home message here is that in general, we're seeing it time and time again. When African Americans are given the standard of care therapy, they're going to do better, and they ought to. They do also have more commonly, as we indicated, translocation 11-14, so they may be more eligible, as you mentioned, for that drug venetoclax. Someone asked how it's classified. It's in a sort of a separate class in and of itself that we don't typically think. It's not formally approved in myeloma, but most patients who have 11-14 will have it approved. So many more great questions that we're not going to be able to get to. I'm going to answer one last one, and then we're going to go to the break. One person asked, when is radiation needed for a myeloma patient? It's a great question, and that's always an individual case. We used to use more radiation. We typically save radiation now if someone really has a lot of pain in an area where there's a collection of plasma cells that may not as easily be gotten to through chemotherapy, like inside a bone, where we focus radiation in a particular area. But it's not a condition where, as much before, we used to use radiation before Brandon did transplant. We used to do radiation before transplant. We've learned not to do that as much now. There are a few more questions I'm going to try and get to at the second Q&A, but I think it's time for us to stand up, walk around. A little timer's going to come up now. We'll take a 5-minute break, get up, move around, get something to drink, another cup of coffee if you're out here in the West Coast, and then we will see you in 5 minutes. And I'm very excited about the second half of the workshop. So thank you so much. Well, welcome back, everyone. I hope you enjoyed your break and a little bit of jazzed up elevator music. I'm always a big fan of taking little breaks like that. I think it's good for a chance for people to get up and moving around. So now we're going to move into the second half of our time together, and not to worry, I know we're running a few minutes behind, but we're going to try and catch up some of that time as we now spend a little bit of time talking about what the IMF is doing to change the course of myeloma as we've described, and then I'll have a brief interview with Dr. Nuka, and then I'm very excited. I mean, I know I said earlier, you don't save the best for last in myeloma, but you save the best for last for Empower workshops. So we're going to hear Charisse and we're going to hear Jamika, and I am just thrilled that they've joined us. They have so much to share with us, and then we'll have a little bit of time for Q&A at the end. Thank you again for coming back after the break. I see we've got a great attendance of folks, and I'm very thankful to see that. So if we can move on to the next slide here, I am going to take a few minutes to talk a little bit about what we've described, as you see here in our program called Changing the Course of Multiple Myeloma. So the IMF's, if you will, empowerment vision is to advance early and equitable access to myeloma information, screening when it's necessary. We don't screen routinely now yet, and treatment in vulnerable communities worldwide. And it's a bold statement, but as I mentioned earlier, our focus today is within the African-American community because myeloma is so unique in this population. But we really want to make a difference worldwide, as we've had the privilege of doing. Brian and Susie Dury, as our founders and our leaders, have just so marvelously put the I in IMF, the international in IMF, and have helped people all over the planet. And that is our goal, to continue that and to reach even further and deeper into our communities. And so with that sort of broad goal, our African American initiative is really an important aspect of that. As I mentioned, the 4 pillars of what we do in multiple myeloma, we know that this is a problem. Many people have tried to make a big dent, and we've seen amazing individual work, like just hearing about Dr. Blue's work today and what he's been able to do, what Dr. Nuka, as you're going to hear in a moment, does in his research, what Charisse and Jamika have done in so many aspects. But we know that more can and should be done. And we believe that the IMF is poised to be able to do that because of our connection. And so our goal is to improve the short and long-term outcomes of African-American patients through really 3 major approaches, which is engaging the African-American community, of which now, for example, our work in Atlanta is being kicked off, as it were, with this workshop. To educate the primary healthcare community, I'm going to come to that in a moment, how important it is to teach them the basics. And Brandon said it so beautifully, how important it is to be able to do that. And then supporting the hematology oncology community as they care for patients, and of course, patients and their caregivers themselves. So part of what we're hoping to empower you to do as an attendee is to know the signs and symptoms of myeloma. If you're here today or you're listening to this, it has been sent to you, and we may not be able to, and you don't really know if you may or may not have multiple myeloma, we want you to speak to your doctor about it. We can't be doctors over the internet to you, and see if you may potentially need the testing that is necessary, and that you talk to your friends and family about multiple myeloma after this workshop. Let's demystify it a little bit. Let's have people understand what it is. I'm going to show you in a moment where you can go on our website to learn so much more, to be empowered, as it were, through the toolkit that we've provided. And so what we have done in our community outreach is that we started back in February with a social media campaign during Black History Month. And we've done, as you can see, there's a whole list of things. I'm not going to go through them all, but we've done workshops like this one. And really, we've built so much of this at our Empower website. And you can start, even just to keep it simple, by going to myeloma.org. And at that website, which is the IMF's main website, you'll see that we have an Empower website, and we have so many resources available to you where we can share with you details of what we have in what we call the toolkit, where you can find a support group. You can learn more about what myeloma is. I do just a really short 3-4 minute video on what myeloma is and what those signs and symptoms are. We can learn more about how you can make that decision, as Dr. Nuka was sharing, about all the different treatments that are available to you, what other resources can be available to you, to your caregiver, and trying to navigate through some of this challenging features of the healthcare system here with drug reimbursement information, and then to hear real life stories. This is Tiffany Williams, who is interestingly both a nurse and a patient, and she can share, and she does share so beautifully her story and finding her voice and be able to speak to her healthcare team about her preferences and share with us a little bit of her journey with multiple myeloma. And then, as I mentioned, not only are we engaging the community, but we are very much trying to educate the primary care doctors who may not appreciate the importance of this diagnosis. I know this has come up several times before, where our goal is so they can recognize the early signs and symptoms. They can distinguish myeloma from other diseases like diabetes. A lot of times we've heard from many of our African-American patients, oh, I was told that my protein in my urine was just from my diabetes. Oh, my low hemoglobin, my anemia, I was told I have that just because I'm Black, or just because I have diabetes. These kinds of things need to be looked at more carefully, and then teach them how to make the right diagnosis. And so we've created this postcard and a program where we just really narrow it down to those CRAB features I shared with you: the calcium, the kidney, the anemia, the bone disease, and the 3 key tests that a primary care doctor can do to actually come to essentially the diagnosis, so that they can send them on to a hematologist and oncologist to confirm that diagnosis with a bone marrow test. And so in doing so, we have started our program, and we've worked in Charlotte, we've worked in Baltimore, we're now, of course, in Atlanta, and we're really looking to many other places. And we think over this next year, we're going to have outreach furthermore into Detroit, into New York, and perhaps many other regions as well. So this is something we don't want to pretend that we can just, do a one and done, where we just come in and fix something and leave that city. No, this is why we're partnering with Emory and Grady and Atlanta and many others in the region, so that it's a long-term strategy. The IMF will always be here to provide the information, as you can see here in our multiple venues of reaching out to us through the website, the specific Empower website and the specific Empower Atlanta website. But we need the local communities to be able to deliver the care to our patients. And so it's so important that this partnership is a long-term strategy. And so although we're going to different places, we're never going to leave Atlanta. We want to be there in the long term. We have marvelous individuals there through our support groups, our support group leaders that have been so helpful to us working through this program. And we really want to help. And if you think you can benefit from our help, please reach out to us. As I mentioned, through the website, we have an info line that runs during the weekdays from 9 to 4 Pacific time at 1-800-452-CURE. And please don't ever hesitate to reach out to us. So at this point, I'm going to bring back my friend and colleague, Dr. Nuka, and we're going to have a little bit of a chat about, and we've talked a little bit about this already, which is great, but a little bit of a chat about myeloma research in African Americans. And we've hit a few highlights already today, Ajay, which is that maybe most importantly is that more work needs to be done. We need to understand this, right? As doctors, we need to sort of come to diagnosis before we can come to treatments. On the other hand, when we use the word research and African Americans or Black patients, there's a tremendous hesitancy, and appropriately so, because sadly of the history of some awful things that have been done over the last many, many years. And so I want us to, a little bit in our chat today, to explain what we mean when we talk about research and how we're trying to understand this condition better, understand what the condition is like in African Americans, so we can have better outcomes for them, that no one is trying to test anybody out of their will, or no one is trying to expose people to things that could be dangerous to them. We want the best. I think Brandon said it really well in our earlier interview, Ajay, when he said, don't complicate things. Let's really, find a way to sit down with people face to face and show to them that we have their best interest at heart. So with that background, Ajay, tell me a little bit about the work that you and the team do at Emory. I mean, I really have been impressed at how much you have done in this area, and maybe you could just tell us from a high level a little bit about it and what's motivating you to do this.
Thanks, Joe, for the opportunity to talk about what we specifically do at Emory. So in the bigger picture, so Emory is located. I'll give you the demographic that we serve and where exactly the problem is and what we've done as a solution. So Atlanta and surrounding areas in Georgia has close to 35% African American patient population. So our clinics clearly reflect the same exact numbers. So 35% to 40% African American patient population. So when we look at the clinical trial enrollments across the country, so just the numbers that I previously talked about, 5% clinical trial enrollments across the country is not, I would say, either there was lack of understanding, lack of awareness about the real need for a patient to be in the clinical trial. And now when we look at in the Emory structure, we see around 35% of our African American patients getting out of the clinical trials. So there was a uniform representation of what the demographic that we serve. So we started to look at where exactly we have succeeded compared to the other places where we have not been as successful. So there is a inherent understanding that we should serve the demographic that we represent or where we are, and that has taken over from the leadership across the board. So that is the biggest challenge that we see at the other institutions, which has never been a problem. Charisse is on the advisory boards for the executive leadership, so that has made our work very, very easier in terms of these the leadership buy-ins. So now I'll drop down into the different aspects of where exactly we have gone in and the specific African American projects that we've done. So we have a good COE program, the community outreach program that really goes into understanding. And coming to the specifically for the myeloma populations, we have the tissue acquisition programs. So understanding what happens in MGUS in African Americans. So Madhav Dadapkar, one of our colleagues that we hired from Yale, has a specific interest in this aspect. So he ran a trial called the SWOG trial, where there were 330 patients that were enrolled on the SWOG trial, of which around 17 to 18% were African American. And what he tried to establish was try to see what is the rate of transformation among African Americans compared to the Caucasians. So there is a very low risk of transformation. It is almost 5% over a 24-month compared to 15% among these patients that enrolled in the SWOG trial. And they were able to get those samples for these patients over an 8-year period. So we have continued the same here at Emory. And when we reach a patient asking them, hey, we want to understand more about what is happening with the African American patient population, the rejection rates that we have are almost less than 5%. So that is purely from, this is not research, this is not a drug that we're using, but this is purely coming in from a sample acquisition.
I think that part is really important, that one of the things we want to emphasize throughout this whole program is that we build trust and confidence with individuals, that we want the best at heart for them. And I think that's partly what hopefully you're building in that community, is to be able to say, we're here, research not to test people like guinea pigs, but to bring to them an opportunity to learn more so that things can be better. When I think of, I think you said it nicely in your talk, when people hear clinical trials, they think about so many different things, Ajay. And I just really want to clarify this point, that a lot of the clinical trials we do are drugs that have gone through a lot of testing already and are very close to getting approved by the FDA, but are not quite approved yet because they need to be used in more patients. And it gives someone an opportunity to be treated with something that they may otherwise not have. And for a lot of our patients, and even though we've got that huge list, they've gone through almost the whole list. And very often they have very little choice left. as to what to do. And this can give them an opportunity independent of their race and background, but that has to be built on that fabric of trust. I know our time is going quickly, but I wanted you to, you mentioned so beautifully earlier the Griffin study and how it's making you scratch your head a little bit to say, remarkably, how much better African-American patients did with that quadruplet versus that triplet. Are you doing other studies or studies like that to further understand if the biology in African-Americans is different, such that there are certain combinations that we can give them that would give them an even better response?
That's a great question, Joe. I think we're looking specifically in the relapse refractory setting as well. So purely I'll give you an example of all the enrollments in terms of the CAR-Ts that we had. There was very interesting data purely from an immune perspective that we're seeing. The rates of the toxicities in terms of the cytokine release syndromes, the rates of the neurotoxicity are much lesser in the African American patients, and the efficacy is much higher. So we probably have treated around 60 patients at Emory with the CAR-Ts for myeloma in various trials. And this is a common theme that we see, and we put our preliminary results as a publication purely to say this is an area that needs much exploration. And if it comes to the access to care as an issue, when we look at the 60 patients, 40% of these patients are African American, so which is giving us a good sample size to compare to see so we are seeing the first step to understand is, are there differences existing? And we are seeing the differences.
That's impressive. I mean, to think on both sides. So for those who may not be familiar, CAR T cell therapies you described earlier is where we literally take T cells or immune cells out of a patient, manufacture them and play with them in the lab so that they are basically trained to attack their tumor. Then we give them back to them. I know this is not an episode of Star Trek. Like, this is really what we do. It's just the most amazing thing. And it can be very effective. But part of the problem is we give those T cells back, the body can react to it and develop this immune reaction, this thing we call cytokine release syndrome. So if I'm hearing you correctly, you're telling me that it appears, I know the numbers are small, that in African-American patients, that this process is working better than in Caucasians, and they have less of that negative immune reaction that we don't like to see, less of that cytokine release syndrome. I mean, that could be very important. I talk about the 3 Ts, the access to the 3 Ts, the triplets, transplants, and trials. I'm going to add a 4th T now and talk our T cell therapy, because it appears from your work that this is something that's very important. I think we all believe in the myeloma community that CAR T cell therapy is going to have a profound impact. But thank you for doing that kind of work. And I'm sure you're going to be following up with more and more to understand it better, because this could really have a big impact in myeloma and within the African-American community.
Thank you, Joe. I think we're doing the biological correlations of why exactly this is happening. And that is actively what we're trying to do now. Yeah,
and you have one of the most sophisticated labs in the world when it comes to looking at the biological connection. So I think that's wonderful. Hopefully we've given people just a little tip of the iceberg of the kind of work and research that Dr. Nuka and his team do that I think can really have an impact in myeloma overall. You all have had such an impact in the whole myeloma community, but specifically within the African-American community. Unfortunately, our time is going really quick. But I just really want to thank you. The percent and just sheer number of patients of African-American heritage in whom you've placed on clinical trials in your institution is a testimony to your team and your group and how hard you work in this. And it really means a lot to all of us, and we learn a lot from you. So thank you so much.
Thank you for having me.
So at this point, I told you that we were very excited to have the next 2 speakers. So Charisse Gleason in many ways doesn't require introduction. Many, even I'm sure watching today, know her. But Charisse, I'm so thankful that you're with us today. And I know that you're going to talk to us about tools for taking charge of multiple myeloma. So I'll turn it to you, my friend. And again, thank you for all you do for our patients and for the community. It's always a joy to share the stage with you, even if it's virtual.
Thank you. And I'll just say, thank you for joining us today. I think for all of us on this panel, it's just such a privilege to have these kind of programs to do with patients. And, we love taking care of myeloma patients, and we love reaching out, speaking to you, listening to your questions. So we'll talk a little bit more about how taking charge of myeloma, but thinking about from the team approach and also some dietary needs. If you go ahead to the next slide, please. So I like this picture, right? Because, we talked about this earlier, that while we're taking care of myeloma, we're taking care of the patient. And the patient's in the center. It's in the center of what we do. And how we choose to treat you, right? So patients will come back from support group and say, hey, so-and-so's on this treatment. Why are they getting something different than what I'm doing? And that's because we tailor our treatment to you. The biology of your disease, the side effects that you've had, it's, your team really needs to get around you and do what's best and how it works for you. And so when I think of the team, right, we have our oncologist, and you may have your myeloma specialist, like the physicians who are here with us today, but you might still have that community oncologist that we collaborate with. You've got your nurse practitioners and physician assistants, your primary care. A lot of times you've come to us because your primary care is the one who actually noticed that you had this abnormality, worked up the myeloma, and then sent you our way. So your caregiver, it's been a little more challenging this past 18 months because in your visits, we haven't always been able to have your caregiver present. Hopefully that's getting better in the center where you're treated. But we also have nutritionists, our clinical pharmacists, so this whole team, and that's the approach that you can see here with the IMF, but that's certainly the approach that we take at Emory, is that we have this team around you. And so what we want you to feel empowered to ask questions, to stop us when you don't know maybe something that we've said or don't understand it, or question us about something that we're suggesting that you do. I always recommend that patients bring questions with you. You wait a long time to see us. I'm like Dr. Joe. I don't like that computer in front of me. I'm not doing my notes while I'm seeing you. This is your time with us, right? And so bring those questions, have no, side effects and things. But ways to communicate with your whole team and understand that you have a whole team around you. You can go ahead to the next slide, please. So, we talk a lot about shared decision-making. I feel like, we've been doing this for some time, but we talk about it more because there are options. It's not all patients get treated the same. And so, while it, typically we see, in particular with an African-American diagnosed in your mid-60s, we see patients that are much younger. And this, right? You're working, you have other responsibilities, things to do. And so those treatments really, we have to make that decision together. Some of you see us in our clinics, but you actually go to a different infusion center. And so we really need to know, what are your goals? What are your preferences? Are there financial concerns? Are there things that we don't know? Are there things we forgot to ask sometimes? So, again, arriving at these treatment decisions together, and especially in the relapse setting, as we've talked about today, in that upfront setting, we risk stratify based on the biology of your disease. For us at Emory, we're talking about clinical trials from day one if there's a suitable clinical trial. But we do make these decisions together. Next slide, please. So how do you know what to ask at your appointment and what you can expect? I find that our patients are very savvy. Patients not only want to know about the treatment they're on, they want to know about the next line of treatment. If this stops working, what are you thinking? Or maybe you're in that state where you're in that biochemical relapse. We're keeping you on your current therapy, but we're already thinking about what's that next line, or what's that clinical trial that might be appropriate for you. So it's good to have those open conversations so has there been a change in your life? Something that we need to know about. Is it challenging for you to get to us? So is it better for us to recommend something that you could be treated with closer to home, or something that's oral if it's suitable for your myeloma. And so you always want to bring these questions to us. The IMF also has tip sheets and questions that they as well can help direct you on what are the questions I should be asking you. I've had patients say that. Is there something I'm not asking you that I should? Oh, go ahead. I keep wanting to forward myself here. So what are those helpful strategies when we're thinking of prevention? How do we remain our healthiest as you're going through myeloma treatment, right? Stress is very challenging. It's on you. It's hard, keeps you from sleeping, can add to your fatigue. So what are those relaxation techniques? Have we referred you appropriately to somebody that might help you with that? What are those complementary things? At our cancer center, we're working right now on further building out our integrative oncology group, and that's looking at those complementary things. Acupuncture, we have a nutritionist, we have a rehab medicine physician who specializes in oncology patients. So all those things that can help. Maintaining your weight, having a healthy diet, and we're going to talk about that a little bit more. Exercise, right? I see you in clinic and I say, are you getting some exercise? And yeah, I'm walking. And I see the caregiver or your spouse over there going, no, and it can be challenging sometimes. Maybe you have pain issues, but the healthier you are, the better you're going to tolerate your treatment and the better you're going to feel, right? So what are those preventative things? In our circle of who's my team taking care of me, there's still that primary care provider. And a lot of times you spend so much time in your oncology office that you don't necessarily want to go back to your primary care, but you still want to have those normal health screenings, that routine health care, those things that we don't necessarily check, right? You still want to maintain your hypertension or your diabetes and remain the healthiest that you can be. If you're a smoker, we really want to stop smoking. That's going to be better for your overall health. Maintaining your dental care. A lot of times if we're putting you on a bone agent as well, we'll make sure that you've had that dental assessment prior to starting and throughout. Maintaining your kidney function. We were very careful about prescribing things for you or having you take things that might be more harmful to your kidneys, even if you have normal kidney function. So those things like ibuprofen, we tend to stay away from that. This is why we nag you about hydration. Everybody feels better when they're better hydrated. And then also protecting your bones. So calcium, vitamin D supplement. Are you walking? Are you getting some bone strengthening type of exercises? All really important to maintain throughout because you'll tolerate your myeloma therapy better and feel better. Next slide, please. So how about diet and the immune system? Yeah, so we need food to give us energy. So you can think about it for like putting gas in your car. So if we're not eating the right things, we're not going to feel as well. So how do we get those nutrients to boost our immune system? We need this for energy. We need adequate protein intake. We talked about fluids, nutrients, right? We need a diverse amount of foods for our gut and to fuel us with energy. And we also want to minimize inflammation, feeding the gut microbiome. What does that mean? And somebody asked in the chat that I noticed, how do I get my normal gut microbiome back after transplant? And so what are those things? What does that mean? What is the gut microbiome? I think of it as this army, right? And we've got good bacteria in there to help break things down, to help us fight infection. And so after transplant, especially if you've had antibiotics with it, your gut just might not be working as well. So what are those foods that you can eat to help you with that? And those are things like legumes, beans, fruit. It's going to give you more fiber, and it's going to promote growth of healthy bacteria. You can go ahead to the next slide, please. So remember, you want this diversity in there. And it really takes about 3 to 12 months for your immune system to bounce back after a transplant. So what are those things that we should eat? We think of a Western diet, higher in sugar, higher in trans fats, higher in saturated fats, which really aren't good for us. And if they're high in those things, then they're low in those complex carbohydrates, fiber, micronutrients, those things that we really need to fuel us and to fuel that energy. And so if you think about this, if your diet only consists in these types of foods, it gives us what's called more of a metabolic induced inflammation. And inflammation, it makes your guts constantly chronically activated to try to counteract this. So especially with high intakes of saturated fats, you get this chronic activation of your innate immune system. And if you said, well, what is that? You know, if it's been a while since you've been in a science class, this is your barrier. This is your protection. And things that are part of your innate immune system are things like your skin, right? First defense against something penetrating, or bacteria. This is why we wash our hands. This is why mask wearing is effective, right? Because we all touch our face, and wearing a mask keeps our hands that might have bacteria out of your face. So, you know, boosting and protecting this system and eating more of an anti-inflammatory diet. So what does that mean? That's more of a plant-based diet. When you think of the Mediterranean diet, you think of plant-based, fish, healthy fruits, fats and oils. This also reduces your risk of heart disease, all things that we want to prevent as we treat you with your cancer. This is also a better diet to prevent certain types of cancer. So does it mean that you can never eat anything off of that? You know, we like to tell people to eat things in moderation. You don't want to diet high in sugar. You don't want to only eat what's typically that Western diet. But if you can really get more to that plant-based fish and things that are healthier, your gut's going to be much happier as well. If you can go next slide. So how about fatigue, anxiety, and depression? Yeah, fatigue is the most common reported symptom, and you look at that, 98.8%. Our rehab medicine physician that I mentioned lectured us the other day, the advanced practice providers, and fatigue is probably one of the biggest things that he sees in his practice and why we referred to him. But he mentioned a study that looked at oncologists when asked about what do you think the number one symptom or complaint for your patients is, and they said pain. And when they asked patients, they said fatigue. Now, it doesn't mean pain's not an issue, it is, but fatigue is huge. And why do you have such fatigue? It could be lack of exercise. It could be from your myeloma itself. How about the treatment we give you? Now, there's not a treatment out there that doesn't come with some level of fatigue. And it can also be what's called myelosuppressive, where we drop your counts a little bit. So that's one of the reasons where drugs like Revlimid and pomalidomide, you take it 3 weeks on, 1 week off, just to get that extra week for your counts to rebound from that. And so, you know, are we asking the right questions? We're good at taking your vital signs and asking you about your pain, but are we asking you the right questions about your fatigue, and how much is it impairing your life and your activity? We also see anxiety, you can see in greater than 35% of patients, and depression nearly 25%. And I don't think any of us are surprised by that. But again, are we talking about these things in clinic? You know, there's other things that add stress to your life, those financial concerns. Nothing we do is inexpensive, and we do myeloma treatment, and we add, well, then you also need to be on this, this, and this, right? So for some patients, they have to decide, you know, which things do I fill? So we should know those things, and we should be cognizant of that when we're prescribing something for you as well. Other stressors, talking about change in social status, sexual function. We're not always good about asking you those questions about how do these drugs impact those normal aspects of your life. So these are the things that we should be talking about. We want you to bring these to us as well and make sure that we're controlling these to the best that you can be living at your full potential and where you want to be. And I'm going to bring exercise back into that, especially with fatigue. And are we bringing some kind of exercise or physical therapy in that can help you with that, even if you're having pain issues? Next slide, please. So what about those financial burdens that you have? There are resources out there. For us, we've got social workers in our clinic to help work you through that. But if we don't know, we don't always get you that help that you need. So medical costs, your premiums, co-payments, traveling to clinics sometimes can be an effort. In the Atlanta area, we get patients from all over. You might be coming several hours for your treatment. And here we are, right now, gas prices are rising. So you might have some challenges with those travel expenses. Medical supplies, getting what you need, as we talked about, the cost of your prescriptions. How about time away from work? We have multiple infusion centers. One of them's open on the weekends, so we can provide that to patients, if they're working during the week. But how about your caregiver as well? Them taking off the time. So all these things we can help you navigate. And the IMF also has guidance you can see there's an info line and also a phone number that you can call to also another way to look for what are those resources that are available to you. Next slide, please. So infection prevention and treatment. So we know that a lot of our treatments and post-transplant, certainly you can have a compromised immune function from this. So good personal hygiene, washing your hands. Can't talk enough about that, especially in the last year and a half. Wearing masks, washing hands, this has been part of our discussion and our conversation long before COVID came in, but it's certainly become more important. Avoiding people that are sick. We're getting a lot of questions. The holidays are coming up. People want to gather. We're having those conversations about, are people vaccinated? What kind of behavior? And in some cases, if you're not sure, right, we're still asking you to be very careful. We're asking you to get the COVID vaccine and the booster, still wearing your mask. We know that you may not, as a myeloma patient, get that same immunity from your vaccine that another patient would. So we're still asking you to be careful, keeping that distance. Immunizations, we tend not to give live vaccines to our patients. Post-transplant, it's going to vary a little bit, but the recommendation for an MMR is the only live vaccine. And typically that's about 2 years after transplant if you're not on steroids. And that's going to vary. And that's something to talk to your local team about. But the other thing, antibacterials, we tend to give you antivirals. So that's that acyclovir or Valtrex, because we see a lot of cases of shingles. Sometimes you might be on an antibacterial as well, just because your counts are dropping. So these are things that you want to let your team know about. If you're having symptoms of fever, 100.4, shaking, chills, even without a fever, you just don't feel right, dizzy, low blood pressure, these are all things that can be very serious for you and that we would want to know about right away. Okay, next slide. These are resources that are available to you. If you haven't gone to the IMF's website, it's just, there's a plethora of information, right? On every treatment out there, as soon as it's approved, they have a pamphlet for it with side effects. Programs like this, we've had different types of programs. Stephanie Boyer, who's our nutritionist in our program, and I did one on nutrition in this past year and how it relates to myeloma patients and side effects from treatments. But somebody is always available to you at the IMF. But certainly talk to your team, talk to your local providers and practitioners, know who your team is. And hopefully, you've got that relationship that you see the joy that they have in practicing and taking care of you, and that they're really focused on you, the patient. I think that's it.
Thank you so much, Charisse. What a fantastic talk. I appreciate every time you present it, to look at the whole of the person and not just their plasma cells. Sometimes as doctors, we can get focused on the tiniest things. So thank you for that. And I know I see some other questions are coming in that we're going to have for you. So we'll do that after we hear from Jamika. So you've all been waiting for this. She's going to take us on a tour of the transit system, apparently. So I hope you've got your bags packed and you're ready to travel. So Jamika, I think if you unmute yourself, there you are. I will turn it over to you, my friend. We're just so thankful to have you. Your passion for myeloma is unparalleled. And please navigate us through this multiple myeloma transit system. The floor is yours.
Thank you. And I'm excited to navigate through this transit system today and to share with you today. You can go to the next slide, please. I want to start with sharing that my myeloma journey reminded me of the days that I traveled throughout Metro Atlanta using MARTA, which is our transit system here. The acronym for MARTA is Metropolitan Atlanta Rapid Transit Authority. And Metro Rapid Transit Authority stood out because this journey really does force you to select a path amongst many options you heard today. It can appear to move rapidly, and it takes you many places physically and emotionally, as you've heard today. And although you're not in the myeloma driver's seat, you always have the authority of when you get on and off a treatment path. So as we said, let's go ahead and take MARTA for a few minutes. And today that is Myeloma's African American Rapid Transit Authority, and discuss a few aspects that impacted me the most as I transitioned from being healthy to living with myeloma starting at a young age. You can go to the next one. Now, this slide gives just a little bit of a snapshot of my journey. I was diagnosed at 26, and some of my symptoms were extreme pain, nausea, vomiting. At one point, I couldn't even hold down a glass of water. That led to kidney failure and my first hospitalization on Thanksgiving Day, which lasted about 3 weeks. My next appointment landed me in an ambulance, ER, and back in a hospital room. I was diagnosed with hyperglycemia. My levels were so high that they said that I should have been in a coma or dead. That hospitalization lasted 3 months. So I spent Christmas, New Year's, and Valentine's Day in the hospital. Finally, my journey to remission ended with about a month hospitalization during my stem cell transplant. That treatment was using my own cells, and my parting gift from that hospitalization was losing my hair and 3 inches in height. A patient as young as I was so uncommon that, as you see, my radiology report says that it's most likely myeloma, although the patient age argues against multiple myeloma. One other thing that's a bit unique about my journey is that I'm about 2 years shy of a decade with myeloma being under control without relapse or maintenance therapy. You can go to the next slide. The trauma from being so young in '99 and just getting started building my career when I was diagnosed so late in the game with the cancer that I never heard of made life difficult. But along the routes that I took, I learned that life goes on. Losing so many things at once is something you must mourn, and there are stages to grief. And to create joy, I needed help to keep my spirits up, and my community was in my corner. Next slide. These maps of MARTA's system shows what happens when you map out your best route. So from 2003 to 2020, you see the difference in how the clutter is on one side versus the other. So just think about how different a ride is when you know how to get to your destination and when you don't. And in my case, as I moved through my stages of grief, I felt the lyrics from a Mary J. Blige song, because of myeloma, I've been up and I've been down, I've been wealthy and I've been poor. As you talk about, we have medical expenses and things of that nature. But I learned that if you stay ready, you don't have to get ready. And to navigate your way sometime, it does take an A, B, C, and D plan. Next slide. During my 3-month hospitalization, I jotted things down. And these are a few pages from my journal during that time. And when my doctor changed one of my IV prescriptions treating my hypercalcemia, a nurse tried to administer the old prescription, but my notes helped to resolve that misunderstanding. Now with the patient portal, I don't have to write as many things down, but I still do use a medical journey when I'm dealing with several providers and diagnoses at once. And here's a little bit. I try to always keep a journal with a positive message on it. And I also use tabs for each diagnosis and provider that I see. I also carry this little notepad. I keep this in my wallet, so when things pop up in my mind on the fly, or I get an unexpected medical call, I can still jot those things down and then put it in my journal or my notes later. Again, I have examples. You always want to keep track of your provider, your conditions, your medical history, track your symptoms, and any questions that you have. And so that's how those tabs can help you in that area. Next slide, please. Now, the memories and pictures that you see here, they remind me that my survivorship is not all about me, especially when I battle with those feelings of wanting to throw in the towel. And listen, helping others is its own reward system. You ever noticed that when someone smiles at you, it's really hard to resist smiling back? Someone's ability to make it can come from sharing your routes during a support group meeting, sending a letter to your House of Representative or Senator that lowers drug care costs, raising money that is used to develop initiatives like this one, or sharing myeloma information that leads to early diagnosis and treatment by more primary care physicians. Next slide. Now, here in Atlanta, 5 Point Station is the center of all train routes. Anywhere you want to go to, you can get to from 5 Points. And your wellness team, your PCP, your oncologist, and supportive care provider is the center to all your treatment routes. Just determine who manages what and for how long. At a certain point after my transplant, if it wasn't related to myeloma, my primary care doctor handled it, not my oncologist. The source of your information also matters when you're advocating for screenings, diagnosis, and your treatment course. So your wellness team helps you to navigate that as well. Now, things can come up, and my oncologist referred me to supportive care. And when that happened, I learned that they stood in the gap between my primary care doctor and my oncologist. And because my Dr. Kursine and my supportive care team cared for my overall well-being, then they also provided more of my needs in a systematic setting. And then they also, as Charisse talked about, provided complementary therapy referrals for me as well. And that was very helpful. Next slide, please. Now you'll find that some routes that I took, I needed to transfer from a train route into a bus route. And treating myeloma and staying healthy is similar. You may have to transfer, as I mentioned before, from one provider to another, or you may be under multiple providers' care. Using continuity of care, linking your medical care teams and facilities will make that process easier for you. You save time, money, and decrease frustrations. I really love this part of the medical field when I go to urgent care because I don't have to pull out paperwork, sign paperwork. I don't show my ID or insurance card, or even have to give my pharmacy information. Having your healthcare data across 1 to 3 systems also help when you're dealing with the disability process and need to submit or release medical records. Speaking of the disability system, an ounce of prevention is worth a pound of cure. So do your research, read all the fine print and policies, know who you can turn to if you have any issues prior to the start of the process, especially when you're dealing with workers' comp, short-term and long-term disability, and the Social Security disability insurance processes. I went through so many changes, learning it could take years to be approved. So please be prepared for denials, document and resolve issues using the proper chain of command. And you might need to transfer some things over to a higher authority, and that could be an attorney or government oversight agency. Next, please. Now, as Charisse and a lot of other doctors talk about, there is a financial aspect to your care as a patient. And to start a route, any train system you have to pay a fee. Here we have to pay martyr's fee. To start your recovery, you have medical costs. Now, those of us who are in a middle income, this can be an especial struggle for us because a lot of systems can use the previous year income. You can have too high of income to qualify, but not enough income to cover your medical expenses, plus your cost of living. It's a fact that stress causes pain and pain causes stress. So you can see how these things link, but you have to break this cycle in order to survive. So financial support programs that cover some of these medical expenses, again, speaking with a social worker and seeking help from a government and nonprofit agencies like the IMF can help you with that. There are resources, again, as you heard, on myeloma.org, the Empower Atlanta myeloma.org website, and also you can simply call the IMF info line. And I also want you guys to also remember they have a lot of YouTube videos and different videos on their site as well that you can view. Next slide, please. Now, sometimes when I wrote MARTA, I had many options to get to the same destination. Now, we have two options when we're communicating with our providers these days. You can call them or you can use the patient portal. For me, the 24-hour access to the provider and being able to send anything at any time, having access to your medical records and early access to even diagnosis, testing, and things of that nature is very helpful when it comes to using the patient portal. I also love a new technology they have, which is telehealth. Being able to schedule virtual visits instead of in-person visits and appointments, knocking out having to travel and wait in the waiting room, especially when you don't feel well, or it's just a follow-up appointment can lock you into using telehealth with a lot of your providers. And using these tools can also, again, lower your expenses so that you can take care of some other things. So if you find that it's difficult to jump onto using these technologies, please allow someone to help you out with that. Next slide, please. Now, when I knew that I had to go from one side of Atlanta to the other side, and it was going to be a lengthy route, a lot of times I would take a book or I would download my favorite playlist to listen to. You need to prepare for your recovery. It is a lengthy journey that affects your mental health. My good friend Tahira told me a while back that my brain was an organ that was affected by my diagnosis, and it also needed healing. Cognitive therapy has been a surprising source for my recovery. And this is a referral that I got through supportive care. The tools that I've learned, like using the PEG word systems and acronyms like WHOPR, which stands for writing things down, organizing it, then picturing it, and then rehearsing that. To recall information like appointments and schedules has been great. One of the tools, for example, that I've learned and I've been using a lot is to associate numbers with words. So I associate hero with the number 0, and then I picture Black Panther for my hero. And then Kevin with the number 11, and I picture Kevin Hart. And so when I need to remember an appointment is for 11 o'clock, I picture Kevin Hart, fist bumping Black Panther, and that helps me to stay on track. So again, these are very helpful with you. Minimizing frustrations and being able to make sure that you're staying on top of your appointments as well. Next slide, please. Your mindset, your attitude, and that financial security, it really does have a direct impact on your healing process. So I want you to remember that you have to break that cycle. And talking through your challenges with the right person is a key to making that happen. Now, I want you to think about when you're lost and you stop and ask for direction, and the person starts to hem and haw and saying as they give you the directions. You know the feeling that you get about following those directions, right? So I want you to know that you'll really find out along your route that learning as you go and relying on your advocates, reinforcements, your community resources, it truly does ease that burden of and that feeling of being lost as you go along the way. And please remember that the source of the information matters, particularly when advocating for your needs, your medical rights, and considering drug trials. Next slide, please. Well, we have reached our destination. I hope you will navigate and map out your model route with more clarity. One final thought that I do want to leave you with is when it gets really tough, think about what you're going through is for another patient. It could be for a caregiver, a family member, or a friend of a myeloma patient. Try also to remember that surviving trauma from your diagnosis and treatment course can bless your community. It can bless your very neighbor. I had a neighbor that moved across the street that was diagnosed with myeloma, and the ability I had to share with her and my journey with her was amazing. So it truly can bless your very neighbor. And I want to thank you for allowing me to share this information with you today.
Well, thank you, Jamika. I could listen to you all day. I mean, you are not just a blessing to your neighbor, you're a blessing to so many people. It almost chokes me up just thinking about how much you've done and how many people you've helped. Just listening to that story, you know, I'm the guy who's always using analogies. I've met my match here. And not to mention that somehow Kevin Hart and Black Panther made it into this Empower workshop is pretty impressive. So thank you so much for your passion, your expertise, and your meticulous detail in describing that MARTA system. That was really, really a brilliant method. I know we only have about 5 minutes left, but I think we can take a few of these questions. I see the panelists come back and join us, which is great. So this is a little bit like the rapid fire round, everybody. So quick answers, if we can, would be really helpful. Dr. Blue, is it possible to have myeloma and not have bone lesions?
Yes, of course. That happens very commonly. As again, bone lesions are only one of the other reasons. You got to think about it. Other things that we look for are kidney problems or kidney injury. Other things that we look for are what they call anemia. People can also have problems with calcium. So those are the main things that happen, but bones is only one component. And for sure, there's many patients that actually do not have bone disease, but it is something that we do watch out, because once those bone disease do happen, unfortunately, they are painful sometimes and impair your quality of life.
Absolutely. Very well said. Charisse, here's a good question for you that comes and says, what is the best way to reestablish a healthy microbiome after transplant?
Yeah, we talked about that. I mentioned that a little bit because I had seen that. So, you know, after transplant, after having antibiotics, you know, you can really lose that. So diarrhea, alternating with constipation, that kind of thing. So advancing your diet to that diversity of diet, right? Eating more things like beans and fruit, things that have fiber, legumes, and just, you know, that more of that Mediterranean type diet that can help with that. We get a lot of questions about probiotics post-transplant, and I would recommend that you talk to your team about that. We usually allow some probiotic use after, you know, a little further out around day 100 or so post-transplant, that can help restore that as well. But really paying attention to what you're feeding yourself, because remember, that's your energy as well.
Absolutely. Great answer. Ajay, are there trials for patients with smoldering myeloma?
Absolutely. We do have 2 ongoing trials at this point. One is a trial called it's an ECOG trial called the DETER. So DETER smoldering multiple myeloma, randomizing patients to lenalidomide dexamethasone versus daratumumab lenalidomide dexamethasone. Both of them are acceptable treatments. There is nothing called placebo that are used in these trials. The second trial that we have is called iberdomide, which is the new drug that I showed you. This is a 4th generation immunomodulatory agent, and it is very powerful in terms of its activity against myeloma. Here we are using it in smoldering myeloma setting. There's a randomization here with dexamethasone or without dexamethasone, but that's for a very short period of time. Effective trials that we have in place.
Great. Yeah. So we are exploring smoldering myeloma, the sort of the pre-myeloma, should we intervene earlier? And Emory has actually been one of the leading sites in the world in this area. Here's a question I'll take quickly. It's sad, very sad, really, where the person is asking, you know, what has happened to the 21? I think I showed 12,000, but anyway, 12,000 people who die each year, even though there are so many treatments. And it's a sobering reminder that we have made huge progress in myeloma, but patients still die every day from this disease. I lost a few very dear patients in these last few weeks. One was a 34-year-old woman. It was very hard for us in my clinic. And it reminds us that that's what propels us. I went into this field because I wanted to take care of the sickest of the sick. 25 years ago, when I started myeloma, patients barely lived a year. And so I think we have to balance the optimism with the realism that we are facing some very challenging times. On the other hand, we have definitely seen huge progress, but we want to continue to fight and fight very hard. I think I'm going to take one more question that I get to give to Jamika, because I so appreciated her message today. And by the way, I should note that there is a Georgia myeloma support group that has regular now virtual meetings. And Nancy Bruno, one of our staff, is very much involved with this. So if you go again, we've said it so many times, to myeloma.org, you can learn more about that. But Jamika, here's a question from someone who is saying, I'm 65 years old, just was diagnosed in April of this year. I'm on my 2nd regimen. I'm hopeful but somewhat fearful because of the high percentage of cancer cells in my marrow. What can you say to me that can help me, quote, keep hope alive?
Well, the first thing is that you have control over your diagnosis. So I know that usually when you're first diagnosed, you have that first feeling of, I can't control what's happening in my own body. But just keep it in the forefront that you do have control over decisions that are happening, even though you don't have control over the disease itself that's in your body. Also, relying on your family, friends, and community is so vital. That's one of the first things that I learned. And then one of the other things I think we overlook a lot of time is humor and laughter. So if you have a favorite movie that's a comedy, something that brings you joy, is an activity, try to do all of those things to remind you that you're living. I don't know if you guys can see, but behind me, that saying says, yesterday is history, tomorrow is your future, and today is your life, live it. So it is so important that you don't forget to live. Do whatever you can in that moment, and that will keep that hope alive for you.
Thank you so much, Jamika, said with such love and passion. I so appreciate it. I wish we could get to all the questions, but I'm very committed to finishing now on time. Just a couple of final things before everybody goes. We are going to have a survey for you, so please fill it out. Give us feedback. We'd love to learn. We make changes at each of these meetings. We've introduced the interview style, for example, when I interviewed Doctors Blue and Nuka. So please let us know what you think about that. Give us feedback about how we can do these more and more. I also want to just remind everyone that we can be reached 24/7 online, but also with the helpline, the info line, which we're going to close this meeting in just a second with a brief, it's only 2 minutes, actually just under 2 minutes, video about the info line. So stay and watch that, perhaps as you fill out your feedback. And indeed, I want to thank again our sponsors who are listed on this slide, without whose help this would be very challenging. So we so appreciate it. And again, I want to apologize to those who I didn't get to all the questions. It's great to see such enthusiasm around them. But please fill out the survey, watch this last video. And lastly, thank you, panel. I learned from each of you today. I was touched both in my mind and my heart by each of you. I love each of you, and thank you so much for your commitment to myeloma patients and to the IMF. and we will definitely be engaging again in the near future. So tee up the video, and I hope you enjoy this and enjoy the rest of your weekend, and we look forward to working with you all again soon. Thank you.
Someone who's just been diagnosed with myeloma has a million questions.
Patients will call with questions about the particular drug that they've been put on or a side effect that they're experiencing.
We get calls from patients who are living with a disease 25 years out, 15 years out, 10 years out, 32 years out. When you hear from patients who are living a long life and a decent quality of life with myeloma, it's hugely rewarding. You know things are working. You know they're getting good treatment from their doctors. The meds they're on are working.
The advances that have been made in the care and the treatment and the understanding of the disease in recent years, the advances have been so tremendous that it's now so much more like managing a chronic disease. And it's wonderful if we can help connect people to different solutions and find ways to make things easier.
It's really important to get good information, get current information. We have contacts all over the world: Europe, Middle East, India, Asia, Australia, and Latin America. We're here to help, to answer your questions, to get you connected to a support group and other patients, to get you a referral to some of the top myeloma specialists in the world. Or we're here to just lend an ear. So give us a call.